Hello and welcome to this podcast brought to you by the Isle of Man Anti-Cancer Association. My name is Malcolm, Chairman of the Isle of Man Anti-Cancer Association and a former surgeon.
And my name's Sandy. I'm the Executive Officer of the Association and a cancer survivor. The Association has posted a series of podcasts on this site with a cancer awareness theme aimed at providing listeners with information about the signs and symptoms of specific cancers to encourage early presentation as a way of improving outcomes. We have asked that in those who recognise that they may have relevant symptoms or signs to visit their GP or practice nurse at an early stage and discuss any concerns they may have.
In this series of podcasts, we want to look at the journey those presenting to their family doctor or practice nurse may set out on. In the previous podcast in this series, we discussed the various investigations patients with a possible cancer diagnosis might undergo. In this podcast, we want to talk specifically about the step after a patient has received a cancer diagnosis and before they commence any treatment.
Sitting in the clinic just after being told that you have a cancer is understandably an extremely difficult time for most individuals in the early stages of their cancer journey. It is the news that, even if you were expecting it, can be so difficult to fully take in. Although the uncertainty about the diagnosis is now removed, it is replaced by the uncertainty of the future you may face.
It is only in recent times that doctors have been willing to inform patients of their diagnosis. In the past, many patients presented late and there were much fewer options around treatments. Relatives would initially be told the diagnosis, usually by the most junior doctor, who often then implored the doctor not to tell the patient. Doctors were poorly trained in delivering such news and often more than willing to go along with such requests. Nowadays, with better communication skills and much more treatment options available, patients are, quite rightly, the first to be informed. Knowing exactly what is going on enables the patient to make decisions about their treatment. Being honest throughout with patients also leads to an enhanced trust between the patient and the healthcare professionals treating them.
Most clinics have specially trained clinical nurse specialists, usually present when the patient with one or more relatives is informed of their diagnosis. This enables the nurse to provide additional support after the consultation is finished. There are other services that patients can be directed to, including, in some cases, talking to a cancer survivor who's gone through the experience that they are now facing. Macmillan Cancer Support and other such services are also there to advise and help people to cope.
The next step in the journey is staging the disease to determine what and when various treatments of the particular tumour are best given. Solid tumours, which compose the majority of cancers, usually start in one place, get bigger and spread. The initial tumour site is called the primary, with any remote spread termed secondaries or metastases. Tumours can spread into surrounding tissues and spaces and metastasize along lymphatic channels to regional lymph nodes and through the bloodstream into distant organs. The extent of the disease or its staging is important in tailoring treatment for each patient. It also has a bearing on the likely outcome or prognosis.
There are various different systems used for staging a tumour. Simplistically, it can be broken down into localised disease, or stage 1, when there is no detectable spread. Stage 2, or regional disease, where cancer cells have spread into the lymph nodes close to the tumour. Stage 3, or distant disease, when there are metastases spread to other parts of the body. And Stage 4, where the cancer has spread from where it started to another body organ, for example, the liver or the lung. This is called secondary or metastatic cancer. Different types of cancer can be associated with different patterns of distal spread, with some spreading more commonly to various organs such as the liver, lungs, brain and bones.
There are also more complex staging systems, the commonest being the TNM system. T stands for the primary tumour, N for the regional lymph nodes, and M for metastases. Each is then subdivided further using a number to reflect the extent of the disease in each area. Such systems are more precise and can be more useful in deciding treatment options.
There are other markers that are becoming increasingly important in the management of various types of cancer. For some time now in breast cancer, the tumour cells have been routinely stained and examined under the microscope to look for the presence of receptors on the surface of the cells, indicating whether the cells have a degree of control from hormones or other factors that are present in the circulation of the patient. Estrogen, progesterone and various Herceptin receptors have been looked for. If a patient's tumour is strongly ER positive, then anti-hormone therapy can have a marked effect on eradicating or controlling the growth of the tumour. In recent times, other cellular factors have also been looked for that can indicate how responsive tumours may be to different drug therapy.
Once all the investigations to determine the stage of the disease are complete, the results are presented and discussed at the appropriate multidisciplinary team, or MDT for short, meeting. In the past, it was usually the first specialist, often a surgeon, that saw the patient who determined their treatment. Each MDT is made up of all healthcare professionals who may become involved in the management of patients with that particular type of tumour, such as breast cancer, for example. The team may involve physicians, surgeons, radiation oncologists, chemotherapists, nurses, and various other therapists, including physiotherapists, dietitians, and even research workers. These meetings are often held weekly, and as many Ireland patients may require treatment in the UK, those involved across will frequently join in by teams or through other online media.
This committee of experts will review all the results available for each individual patient and agree the best plan of treatment for them. This is extremely important in securing the optimal outcome for each individual patient. When a plan has been decided, the patient will be reviewed in the clinic and the treatment plan with its rationale discussed and consent for treatment obtained. Sometimes there is more than one option available, with the patient making the decision as to which they prefer. If patients feel unable to decide themselves, the MDT will usually make the final decision.
After each stage of treatment, with further examination of any residual any resected tumour or additional blood tests or scans, the MDT meeting will review the results and discuss any further treatment options. The patient will be informed of the results of their subsequent review and of the need for any change or additional treatment that may be required.
More information is available at the Macmillan Cancer Information Centre at Nobles Hospital. You can phone them on 650735 or visit their website at macmillan.org.uk. In our next podcast in this series, we will look at the role surgery plays in the management of patients with a tumour. Thank you for listening.